My name is Rosa Beyer. I'm a professor of the practice at the Brown University School of Public Health, where I direct a research center focused on partnered pragmatic research. And I am co-director, along with Janet, of Learn's Scholar Program. I'll be moderating today's panel. Each panelist will spend 10 minutes discussing their experiences developing infrastructure for learning health system research. This will be followed by a question and answer period during which you can ask your questions. You can begin submitting your questions using the Q&A feature as the panelists are speaking, and we'll address them after each panelist has presented. I'd like to begin by first introducing our first panelist, Dr. Beth Skidmore. Beth, please turn on your video, audio, and share your screen as I introduce you. Dr. Skidmore is a professor in the Department of Occupational Therapy and an associate dean of research in the School of Health and Rehabilitation Sciences at the University of Pittsburgh. She is an occupational therapist and rehabilitation scientist with expertise in neurologic rehabilitation. Her research studies examine rehabilitation intervention elements that promote long-term independence, community participation, and health among people with cognitive impairments after stroke and brain injury. As Associate Dean for Research for the School of Health and Rehabilitation Sciences, Beth partners with University of Pittsburgh departments and the UPMC health system to develop infrastructure to support rehabilitation research. Beth, please begin.
Well, good afternoon. In the next few minutes, I'm going to give you a brief overview of a system we call Redwine, which is a data infrastructure that we've developed at the University of Pittsburgh in partnership with UPMC to support rehabilitation learning health systems research. And in doing so, I'll start with a disclaimer that I am an occupational therapist and a rehabilitation scientist who has no training in health informatics, but I'm representing the health informatics team and hopefully able to describe this to you in a way that makes sense to the broader audience. I am involved in this project in my capacity as Associate Dean for Research. I will talk a little bit about the infrastructure and the motivation for the project, but we'll introduce you to my colleagues in the context of the presentation should you want to address any technical questions with them later. So I'll start by telling you a little bit about the University of Pittsburgh Medical Center. UPMC is a large health system. It operates 40 hospitals right now in Pennsylvania, Maryland, New York, and we have a few international hospitals. And then within the UPMC system, we have what's called the Rehabilitation Institute, which has 12 inpatient rehab facilities, 5 skilled nursing, and more than 90 outpatient rehabilitation clinics in Pennsylvania and Maryland. And although the name might suggest otherwise, UPMC and Pitt are 2 distinct institutions. We have separate fiscal and administrative structures. We are affiliated with one another, and we collaborate on health sciences education, training, and research. We even share an IRB. But because we are distinct, we need a thoughtful approach of how we can share data from the health system into the research laboratories within the University of Pittsburgh, and making sure that we follow all the necessary precautions to ensure that these data are secure and managed appropriately. So to respond to this need, UPMC and then our School of Medicine's Department of Biomedical Informatics developed a system that's highly secure and carefully protected, and they call their system Neptune. And Neptune has 3 main layers. The first layer is an identity management layer for managing any personally identifiable information in the health record. This layer resides within the UPMC network and receives a monthly ingestion of data from all of the health records within the health system. And then the second layer is a data layer that contains both structured and unstructured data. These data are extracted and de-identified into a limited data set, and then that limited data set is transferred across the firewall into a secure PIT network that meets all necessary HIPAA and government requirements. And then the third layer is what they call a semantic layer. And that's where there are logic built into the layer, into the system to help standardize the mapping of the data elements from the raw data coming in from the medical chart onto standardized methods and terminologies across health record data so that we can start to compile data across various different health settings and medical record tools. Pitt Health Science investigators can access these data through our IRB. So as they submit their research project idea to our institutional review board, they can request access to the data through the Health Record Research Request System, or R3. And so this is a really great resource that we have available to us to get at the data that we heard about in the last presentation and how we can better understand trends of what are happening and study those. And Neptune is an elegant system for learning health systems research, but it was originally built to address research questions that were more pertinent to our medical and surgical colleagues. And it lacked deep dive into data that were more pertinent to rehabilitation research questions. And so given that, our school has been working with the Neptune team to develop out and build out that rehabilitation research infrastructure. And so we have two members of our team at the school, David Oniani and Yanshang Wang, who are in our Department of Health Informatics that are partnering with the Neptune team. They have the skills necessary to understand these various different elements and then to make them accessible to clinician investigators with all appropriate secure systems in place. So David and Yanshan have been working with our rehabilitation scientists throughout the health system and throughout the university to identify what data sources we're missing from Neptune that are pertinent to rehab research. And then from there, pulling from these missing resources, the missing data elements that we needed into a rehabilitation-focused data mart that we call Red Wine, which stands for Rehabilitation Data Warehouse and Informatics Infrastructure for Research. Then what they do is they use a series of open source tools that come from a system called ODSI, or the Observational Health Data Sciences and Informatics Community, that has a series of standardized infrastructures and platforms to help structure these new rehabilitation data, as well as to help analyze those data within the Red Wine system. ODSI includes tools to standardize data elements, map them onto external standards for data terminology and tools for that, as well as for helping us to visualize the data and do some analyses. And we'll show you some of those here in a moment. Once we've standardized and harmonized the data from the various different settings, we know that we can document in structured and unstructured fields very differently across large health systems. Once we have that standardization accomplished, those standardized elements are then stored for future large-scale observational analyses across various different health record databases in the system. As I mentioned, ODSI provides access to several data analytic tools. There are tools that are, this one is called Atlas. It's free and publicly available open source tool that can be used for data visualization, cohort definition, patient level prediction, and population level estimates of based on the data within the data set. And the thing that this allows them to do is to build kind of a clinician-friendly database or dashboard, if you will, to be able to go in and search the data once we have all appropriate IRB approvals and so forth to move forward. ODSI also provides access to a number of analytic tools, whether they're straight up packages from R or SAS or whatever data analytic packages the investigators want to use. There's also a tool called Hades that has some specific R packages that are specific to observational study analyses. So these are all available behind the firewall for access and use by our clinician investigators. And I think one of the cool features of Red Wine is that it incorporates natural language processing capabilities. So a lot of what we document in rehabilitation research records do not fall within structured fields. They fall within text or narrative fields. And so there's a lot of missing information that could be put to good use in some of our studies. And so Yanshan and David have used state-of-the-art natural language processing tools to go through and cull data from our unstructured fields and our rehabilitation notes. And they even have the capacity to build tailored natural language processing queries based on a particular series of questions that are designed by our clinician investigators. So then they can extract those data elements that may be relevant to our professional interests or clinical scientific interests, or may be important topics that are not usually structured in health records related to social determinants of health, which we know are very important to understanding the quality of our care. So to illustrate this and bring it down to the clinician and speak to my people, I'm going to briefly give you an example of how this might work if you are a clinician investigator. And the first thing that would happen in our school is that you would submit a proposal through the IRB and get approval to that. You would submit a request through our R3 system. And then once all appropriate approvals are in place, you would be granted access to the Redwine system. And this is an example of a part of a question that one of our investigators is currently exploring. Our investigator is really interested in examining the impact of chronic comorbid conditions on physical therapy outcomes and outpatient physical therapy, and wants to try to understand if there is a difference between outcomes in patients who just have a stroke versus patients who have stroke with a comorbid condition of diabetes, given the risk for added cardiovascular impact. And so given that, we would want to make sure that the clinician could access the data for both structured and unstructured elements. And structured elements might include diagnosis and procedure codes. It might include physical therapy outcome measures. It might include some unstructured elements like the evaluation notes, progress notes, or discharge notes. And so this gives you an idea of how they can use this Atlas tool to start going through a point-and-click system to define their cohort based on the broad definition of a diagnosis of stroke, and then a more nuanced definition based on having access to physical therapy, having access to diagnosis of diabetes, and then what that might mean in terms of certain time intervals, or whether you want a first ever stroke versus anybody with a diagnosis of stroke in the data set. And then we can also take a look at the physical therapy progress note and start to identify selected items that can be pulled into a table and standardized in such a way, and then validated across various different patients before we then make this available for investigators to start to analyze. So you can see how they can build on this, drawing from text within the notes. We are in the process of finalizing this system. We are getting the last of our first big data draw of data from the last 10 years in place. But one of the future scientific goals for this team is to start to embed predictive models into the system using machine learning methods, and then to develop point-and-click dashboards for investigators to also create, develop, and test those machine learning modules. So not only taking a look at our process of care, as we heard about earlier, but also starting to take a look at how we can understand where are the potential leverage points to improve process of care. And so I will stop there.
Thank you, Beth. Please turn off your camera. I encourage audience members to begin submitting questions, and we'll address them following all of the panelists' presentations. I'll now introduce our second panelist, Shonali Guadino. Shonali, could you please turn on your video, audio, and share your screen as I introduce you? Shonali is Administrative Director for the Rehabilitation Outcomes Center at the Spalding Rehabilitation Network. She's an occupational therapist with clinical experience in gerontology and skilled nursing. She's worked in various capacities across the Spalding Rehabilitation Network for over 13 years and recently facilitated the implementation of the EPIC electronic health record across the network's 4 inpatient and 25 outpatient facilities, and developed programs to educate staff on this critical source of patient data. As the Administrative Director of the Rehabilitation's Outcome Center at Spalding, she's working to advance data-driven care along every step of the rehabilitation journey from inpatient through community living. Shonali, please begin.
Thank you. Can you guys hear me okay? Well, thanks for having me. So I'm an occupational therapist by background, as was introduced, and I'm the administrator of the Outcome Center at Spalding. And as such, I just want to acknowledge that I'm here representing a large group of people across the Spalding organization. And some people are pictured here, but as we know, learning health system models are really requiring collaboration amongst broad swaths of people. And that's the piece that I'm hoping to talk about today. Should be a nice sort of complement to the data-heavy discussion so far. So first, I'll give you a bit of context for our history here at Spalding. For several decades now, Spalding has been home to model systems programs, which many of you are probably familiar with, but are sort of almost semi-learning health cycles in and of themselves, in that they have infrastructure that includes clinical research, community advisory board, ARMS. The Research Institute at Spalding has also grown exponentially over the past decade or so, with several curated data sets being collected across the organization. And there's been a long history of commitment to continuous learning, as Spalding is the physical medicine and rehabilitation teaching hospital for Harvard Medical School, has an array of clinical education programs that have really been built up under our Chief Learning Officer, Lynn Brady Wagner, who you'll hear from next week. We have patient family advisory councils in each facility, as many places probably do. And in 2017, we entered this new world where all of our sites from acute care to community care are now on a single EMR, because while Spalding is post-acute and we have a few IRF hospitals and LTAC, a SNF, and some outpatient clinics, we're also part of the broader Mass General Brigham enterprise. So all of the academic hospitals, the inpatient community hospitals, the primary care provider organizations, home care facilities, we are all on one single medical record. We built up, with the launch of Epic, we built up our clinical informatics staffing, and most recently our IS department created a data analytics role with someone who has much more technical expertise in querying our very large and complicated data warehouses. It was also around this time that we all know the Impact Act introduced some common data elements across post-acute facilities, and those commonalities only continue to grow over time, giving us some of those core data elements that make it really easy to look at. So when I think about the infrastructure needed for a learning health system, these are some of the building blocks that I think about for Spalding, but without sort of that grout gluing the blocks together. So when we talk about learning health systems, we often talk about accessing the data and data visualization, but an editorial by Charles Friedman last year called attention to the foundational importance of establishing that core learning community to carry learning health cycles forward, breaking us out of what would otherwise be our siloed bubbles, establishing a community that can really be that glue, bringing us all to the same table and building a really strong team. So how do we do this? Who are we even talking about? Ken Cannon in 2012 introduced the 7 Ps framework for identifying different constituency groups in research. This includes patients in the public, providers, purchasers, payers, policymakers, product makers, and principal investigators. There aren't really a lot of venues where all of these groups get to know each other, at least when not when it comes to inpatient rehab, I think. So how do we get to a point where they not only know each other's names, but understand each other and their perspectives, values, motivations, challenges, needs? I'm not going to say that I know the answer to any of this question, but these are things for us to think about. It would be interesting really to think about even today, this really incredible group and organization that has done so much to bring different people across the nation together. I'd be interested, it's curious to see how many of us are operations versus research, and whether or not we meet any of these categories across patients, purchasers, payers, policymakers, really thinking about that full span. I'm going to move us ahead and talk a little bit more about the meat. So there's some examples of how we've started to build that culture of community. And of course, websites and quarterly newsletters are sort of low effort, low touch avenues. But an interesting thing there has been this question. The people that are helping you build those websites and newsletters and put that together are always asking, who's your audience? And everyone doesn't seem to be a satisfying answer. So a little bit more work, and perhaps more engaging also has been our webinars, and we're really excited about our monthly podcast. The podcast captures conversations amongst researchers, clinicians, and people with lived experience in a way that is very accessible and convenient for people to consume on their own time. But again, that question of who is your audience, right? In my opinion, the general public and people with lived experiences can listen and learn about current research efforts. And researchers and clinicians can listen and learn about the stories, perspectives, insights of persons served. We've also created multiple different venues for people to start working together and getting to know each other, from our summer socials to more focused scientific meetings. Those scientific meetings take place every 2 weeks. And once you're on the invite for any reason, you stay on forever until you ask to get out. So we schedule various people to come and present their work with the long-term vision of really presenting all types of not just research, but quality improvement, operational projects, community partnerships. The invite list currently includes researchers, informatics specialists, IS folks, clinicians, administrators. We've got some community members on there as well, but we're hoping to increase that involvement over time and try to figure out how to get everybody to relate to the conversation when we all speak sort of a different language. I'm going to keep jumping ahead. I have too many slides. This is maybe a good example of our version of what we did, kind of relates to the red wine presentation we just heard about, really learning about all of the technical pieces and how they all fit together. And it helps us with the conversation of bringing multiple different groups together, really using the data as a conversation starter. I just want to finish with this one example, because one of the best things that has come out of all of these efforts of building that community so far is the development of a pilot clinic for trauma survivorship that we'll be launching next year. The clinic is really bringing people together in a lot of ways. It's a partnership between Spalding, our post-acute rehab division, and our one of our acute hospitals and their trauma division. So also a partnership between a couple of our research centers and our hospital administration. So really blending that sort of research with operations to have good quality outcome measures and metrics. As we're developing that right now, we're being guided by a really diverse advisory board with all kinds of various perspectives and values and motivations and goals. So we're excited to see what this is going to look like, especially from the angle of data infrastructure, right? What are the key measures? How do we collect the data, share the data, learn from the data in a way that considers all of these various constituency groups and ultimately allows us to improve access, treatment, and outcomes of survivors with brain injury or traumatic injury. And that's it for me.
Thank you so much. Please turn off your camera. Again, I encourage audience members to begin submitting questions, and I'll now introduce our third panelist, Dr. Tim Marshall. Tim, please turn on your video, audio, and share your screen as I introduce you. Dr. Marshall is Senior Director of Analytics and Insights at IV Rehab Network, which consists of more than 500 clinics across at least 14 states. In this role, Tim manages a centralized analytics team, which is responsible for delivering meaningful insights to the network to improve the quality and value of care and to optimize IV's organizational performance. Tim, please begin.
Hey, thank you. It's good to be here. Happy to talk about kind of the journey that we've been going through over the past couple months in developing a really kind of unique and powerful agile data ecosystem to really support the operational effectiveness and growth, and really a focus on our patients for the past several months. And just to kind of start as a reference point, not to talk too much about Ivy, but just to talk about the scale. Essentially, we are developing a data ecosystem to help support an organization that is composed of over 500, probably close to 550 plus clinics as of today. And so as part of our process of going through this development of our data ecosystem and infrastructure, ensuring that we really connected with all elements of our business in order to develop a system that best fits the needs of our growing organization. And so when we started out this process, we really wanted to, keep certain values at the forefront. And one of them is making sure that we are having what's called a data-driven value proposition, making sure that we are using the information that we're collecting to inform our decisions in order to promote clinical excellence to our patients, providers, payers, and additional partners. We wanted to make sure that we developed a system that provided our teammates the visibility on their performance that they needed that can help support their continued professional growth. And using our ecosystem and more advanced analytics to understand how we can best support our patients, which requires us to break down our different data silos to merge and join data from all areas of the business to provide a comprehensive view of our patients and utilize that in order to provide our patients the support that they need so that they can accomplish the goals that they came to Ivy or for their physical impairment. And so when we think about our data ecosystem, it's really an infusion of two things. And one of them is a reporting strategy and analytics, making sure that we develop a ecosystem that allows us to report out to all levels of the organization, from our executive and senior leadership all the way down to the individual staff therapist. And part of it, part of when we were looking through the development of this ecosystem that we wanted to keep in mind was this concept of self-service to provide an opportunity for individuals across the enterprise to go and find and utilize information and not have to rely on other people to get it. So almost developing this concept of these community scientists. We also wanted to make sure that our reporting was smart. We have long been an organization that looks at reporting out on the history. Here's what happened, but that really doesn't offer you much opportunity to change the future because you're not quite sure what's happening as of today. And so we want to develop smart reporting, which not only told the story of what has occurred, but also provided our operators and our clinicians an opportunity to see what will happen if we don't change our story or change the way in which we're operating, and thus providing us an opportunity to either to enhance the patient's experience. And what we also want to make sure that we were able to develop a reporting structure through our data framework and ecosystem that we could run our advanced and predictive analytics and then use that information to infuse it back into our reporting structure so that it could become smarter over time and really give our operators some actionable insights onto the levers of the business that they need to pull in order to improve a certain area of their business. And so this is part of our large transformation that we're going through in moving from a reporting out, kind of describing what has happened and moving more into this, understanding why things occurred, to more of a kind of predictive and prescriptive way of utilizing data to help support the growth and health of our organization with a large focus on our patients. How do we, can we use our designing a data ecosystem that can provide us some trending data on our patients that gives us an opportunity to then improve maybe what a patient's path would be with our smart reporting. So moving from what happened to what can we do in order to change a current trajectory. And so our goal really is to, was part of developing this data ecosystem, was to kind of build and quickly activate a plan that is to allow us to be a data-driven organization in order to use it as an accelerator for driving our care delivery, our operations, and putting us in a position to be an innovator in the outpatient rehab space. And so for us, step one was really hiring a consulting firm in order to bring in really an expert in the field in order to help kind of guide us through this pathway. And that is a key first step if an organization is going through this transformation of developing a robust and agile data ecosystem and framework. They have been fantastic partners for us over the past several months in helping us helping us evolve and really go through the proper steps in a sequential order, taking our time and not rushing to an end product as often we have seen other organizations do, and skipping a lot of those steps that were in between. And so they helped us create a roadmap, understanding what is our vision for our ecosystem, making sure that while we're creating that roadmap, that we also structured some really high value wins along the way. And also, really helping the organization keeping focus on scalability, leveraging our subject matter experts to guide our conversations, to guide the development of our data ecosystem, and keeping the organization really focused on this data-driven decision-making. So we went through some major steps along the way, and one of them really started with evaluating, and that was understanding our business needs. What are the business needs around our data? How do we plan on leveraging it for different areas that are important for the organization? And so we met with we spent 6 weeks meeting with subject matter experts across the organization to ask them these questions. How do you use data in your day-to-day operations? What are some of the challenges that you currently have with the data that's either available or the reporting structure? Next step was also looking at how do we define our current data platform, looking at the current components that we have in place, evaluating other technology platforms or infrastructure that's needed in order to help support the business case uses that we've identified, and then making recommendations to the data architecture and infrastructure that's not only going to allow us to be successful now, but put us in a position to be successful in the future. As part of that kind of evaluation process, we talked a lot about what we aspire to do in 12, 24, 36, and 48 months from now. And the last kind of step on this was to develop a strategic plan, a roadmap, if you will, on how we will kind of implement what we kind of have set forth, and key landmarks along the way where we can start to kind of celebrate these successes as we develop that data ecosystem. One of the big part of this process that we were really grateful for the firm that we brought on board to guide us through this is to get us think about the endpoint first. And this was a kind of aha moment for us, because historically, when we had looked at building out data ecosystem, we looked at kind of our data sources. We focused a lot on the data, where it was and where we thought it needed to go and what form it needed to be in. But when we started this new process of developing our current infrastructure, we started at the end, at the consumer, and understanding the use cases for that consumer. So we focused on the needs of our end users, emphasizing how we would be using the data, how we're using it now, how we would like to use it in the future, and really how can we best answer some of our simple questions now, keeping the focus on those questions that are really important for key strategic areas, as opposed to kind of flipping it around to say, well, I'd like to take all of our ledger data and be able to structure in the way or able to put it in a data lake. Instead, it was, what are some of the current questions or business uses that our ledger data, our outcome data, our schedule data will help us solve, because that helps us understand the relationships the relationships that we had to create between our data as we started to put it in the right ecosystem. And so those 6 weeks that we spent with our subject matter experts, we asked them kind of questions related to these 4 points. One of them was current uses. How do you use your data? What reports do you use and generate? What systems are the truth of source for your data? And the purpose of these questions was to understand, where are we spending most of our time trying to get our data, that allowed us to understand kind of the focal points. We then asked, what are your pain points? So this is what you're using, but what is most painful about these used cases? And also kind of not only what are the pain points for getting your current data, but what are some data that you would like to have that you just don't? What are some questions that you're unable to answer because either the data is not present or we have it, it's just trapped and we can't get it out? We then talked a lot about complexity, about where the data is kept, what are the challenges around exporting it, or around, how many different exports do you need in order to kind of join different exports together to answer some of the questions or put together a report? How many systems are required for that? And then also, lastly, we talked a lot with our subject matter experts around your priorities. What are your short-term focuses? What are the long-term focuses? Where do you need to be? Not where would you like to be, but where do you need to be in 2 years from now and 5 years from now? And that really helped us understand, how do we have to design a system that's not only going to support where we are now, but a system that is going to help us perform and excel in 2 to 5 years from now. After we kind of went through this 6 week of talking with subject matter experts, and the way in which we looked at certain work streams, priority work streams for our organization, and then identified subject matter experts within those work streams, and then scheduled about an hour meetings with these groups of subject matter experts, and had these guided conversations that we kind of similar questions here that we used to facilitate a discussion, to gather this information, to understand how does the organization use information, what type of information is needed, and in what forms. And then what we did is we went back and we started mapping some of these critical areas back to important domains throughout the organization. So here's just an example that was focused on our patient outcomes. Some of the things that were identified or what we call business value enablers were scheduling, understanding our scheduled trends, what patients are more or have stickier appointments or are less likely to drop, what types of patients are more likely to drop and why. Are there certain providers that have higher drop rates? These are all some of the questions that we'd like to be able to answer. And then we map those back to important domains like years of experience. What is the clinician's productivity like? Looking at our patient information and patient outcomes to create these viewpoints for our clinicians. Other areas that were really important in regards to patient outcomes were intake and referral sources, where are referrals coming from? And that allowed us to say what data is needed, what data sources are going to help us provide that information. We mapped from our care delivery aspect, really were a key area that we were focused on is what are the drivers for a successful outcome for our patients? In order to understand that, we need to look at visit over visit trends so that to us identify that we need to be able to join together our schedule data, our ledger data, which provide us our CPT codes on a visit by visit basis, our outcomes data to understand over certain key points of that patient's episode, what was their improvement or lack of improvement like, and are there certain trends that are predictive of patient behaviors? And so having these conversations with our SMEs helped us to identify what are the key questions, how does this relate to important domains within our organization, and then what are the key data sources that are needed in order to help our SMEs answer these types of questions. In addition to understanding what's important to our SMEs, we spent a lot of time talking about kind of evaluating the technical aspects of our data ecosystem. We spent a lot of time looking at what are the core requirements of our system? Where is our data? What are the different sources of the data? What is the current format of the data? And right now, how is that data flowing through our different systems? How is it stored? In what format? What do the different fields mean? Who can access the data? How does the data change? In some systems, we were having full refreshes of the data. In other areas, it was partial refreshes, and that helped us understand what we need to structure the ecosystem like in order to help accommodate or address these different requirements. Part of that conversation with the SMEs was understanding, as I just kind of spoke to, was what data sets need to be joined. For example, in order for us to understand patients that are likely to self-discharge, we need to understand visit over visit trends. We need to understand billing information from our CPT codes. And so those are two very different areas of the business that we need to have relationships between those different areas of the business in order to answer those types of questions. And then, of course, our use case requirements. What is the current state and what could be the future state? What will the quality of the data be like in the future? And then how do we create a system that is robust enough and agile enough in order to handle that? And so we landed on kind of these three other core, sets or value propositions. One of them is the philosophy and the skill set of our end users, knowing that we don't have a lot of kind of our, really back-end technical or developers on staff, but what we have are really passionate end users. And so we have to create a system that is in alignment with our skill set. One of them is cost visibility and knowing what the cost is of the system and the different components of it, as well as you're taking in more data, how that impacts your cost to maintain a data system. And of course, security, making sure that we have a very secure platform. And so we landed on three themes. And it's important that you have these three themes because they're the ones that kind of guide your development. And one of them, the first theme being simple, proven best practices. We want to make sure that we design a system and use technology that was proven in the industry, that was not kind of old tech, but new tech, and that the new tech was allowing us to be kind of agile and dynamic as we move forward. And then, of course, security first, making sure that since we have patient data, that our system designed with top end security. From how do we manage different accesses and privileges throughout the organization? Who can access the data? Who can't? What can they do with the data, et cetera? And then lastly, market attractability, using a tech stack for the data platform that increases our value, which allows us to either, a tech stack that allows us to easily ingest new data sources as certain questions arise, be able to empower our citizen data scientists, so our different members of our organization who have questions so that they can self-service their data needs, as kind of these really important themes as we design on our data structure. And so once this is complete, we then kind of developed a rough draft of what this infrastructure may look like, from identifying where our data sources, how do we ingest that data, what are the different ways, our different pipelines for ingesting that data, depending upon the source of the data, from our structured EMR, ADP data, different applications or outcome systems. How do we ingest that data to our unstructured data and different API connections? And also considering if we were to hook up external data sources, how we might ingest that as well. We also had to think about how do we model it and enhance our data, and what is the right tech platform in order to do that as well. And so in this case, one of the key decisions that we were landing on is what should our data warehouse be, based on how we would like to leverage our data platform in the future. And so there was a lot of considerations that were going into place. Do you use something like Databricks? Do you use Snowflake? What type of Azure environment are we going to be in? And it was all, our decisions were all based on the conversations we had with our SMEs, our use cases, and how we would like to leverage this tech in the future. And then how do you transform and deliver it? And once you deliver the data, is how do we visualize it and how to report it, and making sure we have the right reporting structure that's kind of tacked on the end of this, so that when we extract the data, we can create the right reporting and visualizations to effectively communicate to our operators, our clinicians, how they're doing across various aspects of the business. Kind of the last part of this was, once we identified what our business case use that to inform the way in which we design our infrastructure and ecosystem, is to map out how we kind of work through this. And that helps us set very kind of deliberate and meaningful milestones that we can make sure that we address. And so, phase one really talking about kind of how do we ingest and structure out the data? How do we just understand more of a descriptive part of the business in that first time point? Moving into more of phase two, which is once the data has been adjusted and structured, to then creating visualizations and reporting out on key metrics. And once you have that foundation of reporting and metrics, is then using it to run more of our predictive and advanced analytics to find more meaningful kind of trends and insights within that data. And then how do we then pull that back into our reporting and analytics to communicate these findings out to the field. So when we look back at kind of how we've kind of gone through this process, developing this data infrastructure, one of them is it requires it's a long process that requires a long-term commitment. And one of the ways to kind of make sure you continue to move through this process is to make sure you hire a good consulting firm to be your partner. And with that partner, kind of hold the organization accountable to continue to hitting certain key milestones, engaging the organization throughout all levels, starting at the executive leadership all the way down to the end users, which would be your subject matter experts. That firm, that partner, is key to kind of moving through this process and making sure that you do design and kind of stack the right tech that's going to be needed to support your data needs. Really spend time understanding the use cases. That was so critical for us that we didn't just jump towards where's our data and how do we put it in a certain place that we can then leverage. We spent a lot of time as to understanding how we're going to leverage that data in the future, and then make sure that we design the back-end infrastructure and ecosystem to support those use cases. And then develop a roadmap, making sure that you are developing a very robust roadmap that really highlights kind of key milestones, so that you can celebrate when those key milestones are reached, which kind of helps the organization become motivated and maintain their motivation and energy to supporting the process of developing a kind of the build out of an agile data ecosystem, because it's not something that can be done within a month or two. It's a several months and year commitment to really kind of bring to life this ecosystem. So, okay, thank you so much.